So now let's get into the surgical management of PNETs. So the way I approached this was to go through the NCCN guidelines and then try to find where there is and where there is not good data for the things that the NCCN recommends. So we'll go through each kind of point in the bracket on the NCCN guidelines, and then we'll try to cover some literature if there's good literature. If not, I just kind of gave some general points. So this is a paper from Jennifer Seng's group where they looked at the SEER database, which classifies patients as uh, surgery not recommended versus surgery recommended, and then you can look at whether those patients actually got surgery or did not. Basically, what they're showing here is that if you were recommended for surgery but didn't get it, you do much worse than if you were recommended for surgery and did get it. And then these patients, probably either had comorbidities or unresectable tumors, so they were going to do worse no matter what. One thing to notice is that the time here is very long. So you're talking about 10 years here, even for the not resected group. You have some patients surviving that long. But clearly, surgery has benefit when indicated, which is a fairly obvious statement, but this does show it. And then they did break it down into different groups. The one thing that I'll actually bring this back a little bit later, but this is distant, meaning metastatic disease, and they did still show a benefit of surgery in that group of patients. So, and then in the head of the tumor, so meaning basically either requiring enucleation or Whipple, those patients did show some benefit too, although the line crosses zero there. All right, so getting to the NCCN guidelines, we're going to talk about non-functioning pancreatic tumors first. So again, this is not an insulinoma or glucodenoma specifically, as those have their own recommendations. Non-functioning tumors, so you're going to get some imaging. They do talk about somatostatin receptor-based imaging to include dotatate here, so that has made it to the NCCN guidelines. US has indicated, and then biochemical evaluation as indicated. Again, there's not a whole lot, or that's not something that we typically do here. That would mean chromogranin A, which is sort of unreliable. So if you have metastatic disease, we'll talk about that later. So first we're going to talk about local regional disease, what to do with that. And these are T1 tumors, and you have multiple options. So we'll talk about T1s first. Multiple options, which is going to tell you up front that the data is not perfect, that there's no clear answer. But you see enucleation is a possibility, resection, or observation. And then each of these resections do say plus or minus regional nodes. We'll talk a little bit about that as well. So first thing, let's talk about who you can observe and what the data is there. So patients that you can't observe, let's talk about a little bit of the data there. So this is a retrospective review of non-functioning pancreatic neuroendocrine tumors less than 4 centimeters. Again, these are sporadic, non-familial, and they talk about no radiographic evidence of invasion or metastatic disease. So again, that's a little bit subjective, but no obvious nodes, no obvious infiltration into adjacent structures, and no metastatic disease. So these are tumors that look to be small and look to be low grade by imaging. They have to be sporadic, have to be non-functioning. So this group looked back at 10 years of their data, had a mean follow-up of almost 4 years, had no patients in the observation group cross over to the surgery group, and no disease progression or disease-specific mortality in the observation group. So this is sort of busy, but I just wanted to point out a couple things. So this is, again, 10 years. They had 72 non-operative patients, only 49 operative, so not a huge experience. But the biggest things to notice here are, so this is on imaging. They are going to have hyperenhancement on CT, which indicates a benign tumor in the vast majority. No calcifications in the vast majority. No pancreatic duct cutoff, which would be a worrisome feature on imaging. No image of, or very little evidence of chronic pancreatitis, which is again worrisome on imaging. And then no peripancreatic lymph nodes, or excuse me, very few peripancreatic lymph nodes greater than 5 millimeters. So those are the features that you're looking for if you want to sit on a tumor and feel good about it. You have no calcifications, no pancreatic duct cutoff, no chronic pancreatitis, and all small lymph nodes. And then the tumor should be hyperenhancing on arterial phase of a CT scan. And then one thing they did point out is in their operative group, their point is that these are not benign operations. So 25% had a complication, and 27% had a grade B or C leak. So again, this is pancreatic surgery, so it is going to be there is going to be complications. So you have to really consider that before making a quick decision to go to the operating room. Thought this was interesting. Only 5 patients in their operative group had node positive disease. So very few patients had node positive disease with this highly selected group. The conclusion of this tumor: small, non-functioning PNETs usually exhibit minimal or no growth over many years. Non-operative management may be advocated when serial imaging demonstrates minimal or no growth without suspicious features. So again, highly selected group, but these were successfully observed without surgery. This is another paper somewhat similar. This is from the MSK group, retrospective review of non-functioning PNETs, less than 3 centimeters this time, and again, only sporadic. Again, 10-year review. They had some more patients, 464. So what they did here, these are initially observed patients. They did have crossover. Again, no familial syndromes in either group, so those dropped out. Initially, 104 patients were observed. 26 of them converted to surgery. 78 stayed in observation only. They took their 314 that had been operated on, and they did matching to try to match these 78 observation-only patients, and they got these 77 resection group patients that were matched by imaging features and stage, again, preoperative stage, to try to make some comparisons between those two groups. So again, kind of a busy table, but try to point some things out. This is their Kaplan-Meier curve. So you can see the two groups. This is overall survival. They both did very well, and you can see that basically no difference between the two groups. And this is, again, the matched group. So this is the 78 patients who were not resected, who did not cross over, versus the 77 matched resection group patients. So something to point out here, again, based on the imaging features up front and the small size, only 1 patient out of all these had node positive disease. So fairly good job of predicting nodal disease based on imaging. This is an interesting graph out of this manuscript where they looked at all the patients that were initially observed and charted their change in tumor size over follow-up time. So the yellows are the ones that were actually converted to resection. The blues were the ones that were observed. So you can see that change in size was clearly not the impetus to resect these patients, as only 3 of them had a significant increase in size. There was, what you see overall is that 51% had some increase in size, 31 actually decreased in size, and 18 showed no change. So that gives you some idea of the natural history of these tumors if they're observed. Conclusion here: in this study, no patients who were initially observed developed metastatic disease or died from disease after a median follow-up of almost 4 years. Observation for stable, small, incidentally discovered PNETs is reasonable in selected patients. So a couple retrospective reviews that support the idea that you can observe some of these. Typically, it's going to be less than 2 centimeter tumors that have no suspicious findings on imaging. So next option, let's talk about enucleation. So I couldn't find any great data that was very convincing about whether to enucleate or not. So I just tried to kind of summarize some basic stuff. So these are just some general notes about enucleation. Again, the data kind of goes both ways on this. But in general, non-functioning PNETs, you can consider enucleation for less than 2 centimeters, sort of the same group of patients that you might just observe and not operate on at all. Really only considered when the tumor is away from the pancreatic duct, because if you're too close to the duct, obviously you're at a very high risk for a leak. and typically only for tumors of the head, because you're trying to avoid a Whipple if the tumor is out in the tail of the pancreas. Generally, just do a distal pancreatectomy, and then you can argue about whether a spleen preserving distal pancreatectomy is appropriate. But one thing that was interesting is that multiple studies have shown a considerable leak rate with enucleation, around 40%. So potentially you're trying to save the patient morbidity, and then the risk of leak might actually be higher with enucleation than with a formal resection. And then just a note of caution, PNETs 1 to 2 centimeters in size have been shown to have a 7 to 26% chance of lymph node metastasis. So those two retrospective studies showed very low risk of lymph node involvement with these highly selected patients based on not only size but also imaging. And then most people would argue you should also be selecting based on initial biopsy. So if the grade is higher, or if they're not well differentiated, or if the imaging is at all concerning, those are the patients that enucleation is probably the wrong answer for. And again, the NCCN recommends getting lymph nodes even when you do an enucleation. So that's another thing to keep in mind, that if you're going to enucleate, if you're worried at all about these patients being a little more advanced, then you should sample the lymph nodes. And if that is in the tail of the pancreas, you should probably just be doing a formal resection at that point. So very limited role for enucleation, but potentially for smaller tumors that are in the head that you don't want to commit to a Whipple for, but you should do, and tumors that are out on the periphery, so you'd be doing an enucleation with periduodenal lymph node sampling. So NCCN guidelines are very vague about whether, it's plus minus regional nodes in each one of these. So I just wanted to kind of go over a little bit of the data on that. This first article is from our esteemed colleague, Dr. Jeff Krampitz. So this is from the Stanford group, and they combined data with the NIH and argued for lymph node positivity as an important prognostic indicator. So they looked at a large retrospective cohort of patients and basically looked at patients with liver mets, patients with positive lymph nodes, and then patients with neither. And this is their initial evaluation of overall survival of the whole cohort. And I think this is interesting because they showed that there's no overall survival difference initially, but then they looked just at the NIH cohort, which had a longer follow-up, and they looked at disease-related survival, and they actually showed a difference. So I think the key here is you're talking about a very long period of time, and it's difficult to show a difference in overall survival without very long follow-up in these patients, because in general, they tend to do very well. So even the lymph node positive patients did well, and it took a long time to show a difference between these cohorts. So when looking at these trials, you need to understand that it requires a long follow-up to show a difference in overall survival. And it just tells you something about the prognosis of these patients in general. But the conclusion of this paper was careful evaluation of number and extent of lymph node involvement is warranted in all surgical procedures for PNET. So their argument was certainly that if you're going to go operate on these people, you should be taking lymph nodes while you're there. So what are the predictors of lymph node positivity pre-op? So it's not very helpful to look at the predictors afterwards, but on imaging up front, size, and then radiographic evidence of lymph node positivity, obviously. And then this one is variable. So grade 2 tumors have been shown to have a higher incidence of lymph node positivity, but you have to go off of your pre-op biopsy, which may or may not be reliable. But there is evidence out there that small grade 1 radiographically benign tumors may not require a lymph node assessment. And really that's a similar argument to saying that you can observe them. Because if you're going to do surgery, you should likely at least biopsy some of the nodes, especially in non-functioning tumors. But if they're small, they look benign on imaging, and the biopsy shows grade 1, then they have a low chance of having lymph node positivity. So just briefly to finish up on the small, on the T1 tumors, distal pancreatectomy and Whipple are options. when the tumor is more concerning on imaging or has evidence of lymph node positivity. Um, so then let's move on to the larger tumors, more than 2 centimeters. And the other thing, these aren't just larger than 2 centimeters. This also includes smaller tumors that appear invasive on imaging or appear node positive on imaging. So any of these tumors that have concerning imaging findings then fall down here. And this is pretty straightforward. You do a definitive resection and you get regional nodes. Again, that includes a splenectomy if you're doing a distal pancreatectomy. So that one's pretty straightforward. And then just quickly, I wanted to talk about gastronoma and insulinoma because the NCCN splits these out and gives different recommendations. So a gastronoma, again, you're going to do your upfront testing. The biggest difference here is when you talk about local regional disease, the first thing to do is to manage the symptoms. So you don't take these patients to the operating room right away. You manage their gastric hypersecretion with PPIs and or octreotide lanreotide. So first you manage their symptoms, and then we'll go through each of these. So occult primary tumor, I think this is a difficult scenario, but not a lot of evidence here one way or the other, but you have the options of observing those patients or doing exploratory surgery to include a duodenotomy, an intraoperative ultrasound to try to find that tumor. And then periduodenal node resection for these because they're going to be gastronoma triangles, so you want to take those nodes. And then if they are located or localized, if they're in the duodenum, do a duodenotomy, intraoperative ultrasound, and then local resection versus enucleation. And here, the local resection versus enucleation, the things I saw in the literature were 1 centimeter cutoff. So if it's smaller than 1 centimeter, you can open the duodenum and enucleate the tumor out of the duodenal wall. If it's greater than 1 centimeter, you need a full thickness resection of the duodenum in that area. And then pancreatic tumors, if it's peripheral, you can do an enucleation. If it's central, you have to do a formal resection. And again, there are some caveats here with enucleation of a gastronoma because the majority of these are going to be malignant, so you treat them sort of like non-functional. So all those caveats about when to enucleate and nodal dissection apply here, with the recommendation here being that you do a node dissection even if you do an enucleation. Excuse me. So, and then just again, the big thing that you need to keep in mind here is if you're going to go look for a tumor, or if you're going to get a gastronoma, unless it's very clearly localized and you're very confident that's the only one, you should be doing a duodenotomy, intraoperative ultrasound of the duodenal wall, and palpation of the duodenal wall as well. So insulinoma, pretty similar local regional disease. First, you're going to treat the symptoms, and then if it's exophytic, you can do an enucleation. They make the point to say consider laparoscopic. I think their point here is that keep the surgery to a minimum because the majority of these tumors are going to be benign and present very early on. So the deeper tumors, you do still have to do a formal resection, but these exophytic peripheral tumors, and again, these are generally going to be pretty small when they present, you can do enucleation. And then metastatic disease, we'll talk about that with the other, all the other things, or all the other metastatic tumors. So just briefly, PNETs in men 1 and how that affects your surgical management. The biggest thing is that the majority are going to be multifocal. So the role of surgery at all in men 1 PNETs is actually controversial because they're so frequently multifocal. So you really should only operate on these multifocal tumors if they're symptomatic and you're confident that the one that you're going to take out is causing the symptoms. And typically you want to see a tumor greater than 2 centimeters so that you can feel fairly comfortable that taking that tumor out is going to decrease symptoms, or rapid growth on imaging indicating a malignant tumor. That would also be something you'd operate Um, when surgery is done, you want to remove all identifiable tumors. Again, you're going to do an intraoperative evaluation, including a duodenotomy if it's a gastronoma. You're going to do intraoperative ultrasound of the pancreas to look for multifocal tumors. And then preserve some pancreas for as long as possible. So these would be patients where enucleation might be the right thing to do if they have multiple tumors, and you want to try to save them some pancreas throughout all this. So last thing from the NCCN guidelines is metastatic disease. So first we're going to talk about specifically metastatic to the liver, so liver-directed therapies. So some of these slides I took from Dr. Lee. He gave a talk recently on this topic, so I stole some of his slides. So the rationale for surgery, there's a couple things we want to do. The first thing we're going to try to do is control symptoms. So what's the data on that? Surgery in these patients will relieve symptoms in 90%. That's good. But the symptoms will relapse in 2/3 after 5 years, with a median time to relapse of 3.5, almost 4 years. So you are doing them some good by operating, but you want to make sure that what you take out, you want to feel confident that what you take out is going to relieve their symptoms. So this is again back to Dr. Sang's paper just quickly. So again, distant disease to include liver mets, there was a benefit for surgery. And then specifically, just to give you an idea, their median survival for resected distant disease was 5 years, whereas if they had recommended surgery for distant disease, but the surgery was not done, the survival was only 30 years. So you're doubling survival by this data by resecting even distant disease. So this is a paper. This was a review paper where they reviewed 29 studies looking at surgical resection of hepatic metastasis from PNETs, from all neuroendocrine tumors. Surgical resection associated with improved progression-free survival, as well as symptom control. So symptom control in 95% of patients with surgery. And then overall, over the whole review, there was improved progression-free survival as well. Surgery was associated with 5 and 10-year overall survival rates of 71% and 42%. So this paper favored surgical resection whenever possible. And then this paper was a large multi-center analysis of surgery versus TACE, essentially. So the overall survival curves, you look at, overall survival curves, yellow line is TACE, blue line is surgery, and you see a huge difference. However, they acknowledge the fact that these patients are going to be highly selected, so the patients who could actually tolerate surgery were going to get surgery. The patients who couldn't or had so much disease that surgery was not deemed beneficial are going to be in the TACE group. So there's sort of going to be a natural difference between these groups based purely on selection. So they did some propensity score matching to try to match up patients between the two groups, and still showed a benefit of surgery, although not quite as dramatic. But improved overall survival of surgical resection versus TACE. So this is a slide I took from Dr. Lee's presentation, just kind of summarizing the principles of surgery for neuroendocrine tumors with liver mets. So basic principles: the liver should be the dominant site of progressive disease. At least 90% of the tumor should be removed with any surgery that you do. And then alternate therapies should be less attractive to surgery because of efficacy, durability, symptom management, or side effects. The other thing that I think other people might throw in here is thinking about the grade of the tumor. So again, you can have these moderately differentiated but high grade by Ki-67 or by mitotic count. And those, there should be some caution there in patients who are higher grade but still considered a PNET. When they have metastatic disease, your long-term outcomes after surgery might not be as good. And then just kind of an example of how aggressive people are surgically. This first paper is out of MD Anderson, Laura Prakash, the first author, just describing some portal vein thrombectomies done during resections of pancreatic neuroendocrine tumors. So uh, they had 9 patients who required a portal vein thrombectomy during surgery. More than that, about 25 patients who had some sort of portal venous involvement, but 9 of them had tumor actually extending up into the portal vein and had a thrombectomy. And did well from that, no mortalities, and 7 of the 9 were still alive at 33-month follow-up. And then this is just a paper describing surgery when patients had vascular involvement to include some SMA reconstructions in operating on these tumors. So the point being just that with especially well-differentiated low-grade pancreatic neuroendocrine tumors, you can be very surgically aggressive because the prognosis is so good long-term relative to ductal adenocarcinoma. This is a slide that I adapted from a recent endocrine talk. Jonathan Zagzag sent me this. Dr. Shabbat's gave this talk at one of their meetings. I thought it was a nice slide to kind of summarize. So sporadic PNETs, again, not familial. Those are treated differently, but first question, functional. If the answer is yes, and it's an insulinoma or glucagonoma, then you ask, is it greater than 2 centimeters or near the pancreatic duct, in which case you do a formal resection. If it's less than 2 centimeters and not near the pancreatic duct, exophytic or out on the edge of the pancreas, then you can do an enucleation. And again, I think based on the NCCN guidelines, you would add a nodal sampling here as well. The other functional neuroendocrine tumors are treated differently. So VIPoma, somatostatinoma, glucagonoma are treated just like non-functional. So this whole side is the non-functional. First question, is it metastatic or not? So let's start with the non-metastatic localized disease. And then is it well differentiated with no concerning imaging findings? And then also less than 2 centimeters. Those are the ones that we said we could potentially observe. Some people might add enucleation to this, but these are the ones that are you have a low concern for nodal disease, so you can observe them or potentially enucleate them. And then if they are not well differentiated, or they have concerning imaging findings, or are grade 2, I think these are all the reasons that you could argue that you do need to worry about nodal disease, do need to worry about metastatic disease eventually, and those are the ones that you should resect. And then this is over in the metastatic disease. And this was interesting. He added this caveat: if it's metastatic and high grade, go straight to medical therapy. So, I think this is an area where there's going to be controversy, but potentially if it's a high grade metastatic, then that might be somebody that you wouldn't even think about resecting because they're not going to have quite the benefit long term as the G1 or G2s. So in these low-grade tumors, the recommendation is any of these: resection, ablation, embolization, medical therapy. Again, I think the data would show that if resection is possible, that's the best choice. There's some data actually from MD Anderson that hopefully Dr. Lee can share with us on Thursday night, that a combination of resection and ablation is probably just as good as resection if you can't do a formal resection of all the disease. And then embolization, we kind of talked about the paper of surgery versus TACE, with surgery being better. And then medical therapy. Medical therapy is improving for these. So we don't really have head-to-head data for the new medical therapy versus surgery, but I think the conventional wisdom is that when resection can be done, it is the best choice.